And again, good afternoon and good evening to everyone. Welcome to the Anatomy tutoring session, our fifth tutoring session. We're looking forward to our nice, good presentations in anatomy, embryology, and histology today, and we'll flow in our normal order that we do for again anatomy, histology, and then embryology this time around. So I don't really have a ton of announcements from the Anato-Bee. The only thing that we wanted to say is that the registration for this year closes in January. So if you could go ahead and tell all of your classmates that we're interested in participating, that the time for that is going to be running out shortly after the holidays. So that's the only thing that we wanted to share with you guys. I'll again be putting for our research survey the information in the chat for you guys. And again, that's not going to affect your performance in the anatomy competitions in any way, shape, or form. And it's completely optional if you choose to do so. So with that, I'll turn things over to our moderator, Dr. Bill Frank.
Good afternoon, good evening, everyone. Our first presenter is Kyle Yang from Drexel University College of Medicine. Kyle is a second-year medical student at Drexel University. He went to UCLA for undergrad and majored in biochemistry. In his free time, he enjoys watching movies, playing games, and sleeping. He also enjoys traveling when he gets a longer break from school. His specialty of interest is emergency medicine, but he is open to exploring other specialties as well. So with that, Kyle, you are on.
Hey, good evening, or everybody. Hope everybody's doing well today. I just share my screen here, and okay. So just wanted to say hello, and I will be covering cardiovascular anatomy today. Okay, starting right off with our lecture objectives. We want to first identify the internal and external structures of the heart, explain the basic function of these structures, trace the pathway of blood through the heart, explaining which parts of the heart contain poorly oxygenated blood versus oxygenated blood, identify the main veins and arteries that supply the heart, and identify the great vessels of the heart and their branches, while also explaining the general function of the great vessels of the heart. Okay. So jumping right in here with where the heart is located and what the heart is, I'm sure all of you know, the heart is a muscle that pumps blood to various parts of your body. It is a vital organ for the functioning of your body overall. And it is located in the thoracic cavity in the mediastinum. And so I have here the mediastinum where my cursor is, and the mediastinum is generally divided into 4 parts. We have the anterior mediastinum colored in yellow. It's just this little slim part here. The middle mediastinum with the pink color, the posterior mediastinum with the blue color, and the superior mediastinum here in green. And then over in these pictures here, you can see the mediastinum, which is sort of outlined by this yellow dotted line here, and you can see it contains the heart and a bunch of the great vessels that exit and enter the heart. Okay. Okay, moving right along to the external structures of the heart. First off, the heart is encased within a fibrous sac called the pericardium, and you can see the pericardium right in this corner where my cursor is, and so you can see it's a sac that really contains the entire organ. It really has 2 layers. There's the visceral pericardium, which sits directly on the surface of the heart, and is shown out here outlined in the red box. This purple thin line right here, it goes directly on the heart. And then you have the parietal pericardium, which is this layer right here where my cursor is. And in between these 2 pericardial, spaces, these 2 layers, there's a space right in the middle that's filled with fluid, which sort of lubricates the heart and allows it to contract and move more smoothly. And we call that fluid the pericardial fluid. In addition to the sac, the heart is also covered in fat and adipose tissue, along with the coronary arteries and the coronary veins and sinuses. Okay. Moving right along here to the internal structures of the heart. So the main anatomy of the heart can really be divided into these 4 chambers. And these four chambers are where the blood flows. First off, we start off in the right atrium, which is right here. And then the blood flows into the right ventricle. And then it flows out to the lungs to be oxygenated before returning to the left atrium right here, and then being pushed into the left ventricle, and finally through the aorta to be distributed to the rest of the body. So a little bit more on the flow of blood. So as we all know, the heart pumps, and when the heart is, before it pumps, when the heart is filling with blood, it's a process called diastole. And then finally, when the heart contracts, it's called systole. And we see here that the deoxygenated blood enters the from the body, enters through the right atrium, as I was mentioning previously, before being distributed to the right ventricle and then being passed along to the lungs. Important to note here, generally, I think of arteries as moving oxygenated blood away from the heart to the rest of the body. But in the very special case of the pulmonary artery, it actually moves deoxygenated blood to the lungs before returning with oxygenated blood through the pulmonary veins. That's an important distinction to make here, and it's important that you remember this exception to the rule that generally arteries have oxygenated blood in them. Okay. And then we want to talk about the valves of the heart, which really exist to prevent backflow from the heart. We have the tricuspid and the bicuspid valve. The tricuspid valve exists on the right side, and the bicuspid valve exists on the left side. And they're named tricuspid and bicuspid because your tricuspid has 3 leaflets, and then your bicuspid has 2 leaflets. Okay, and then from here, I have a short little 1-minute YouTube video for everyone to watch here that sort of demonstrates how the heart flows. Okay. And I hope that really helped to provide a sort of live visual for what happens when blood is being pumped throughout the heart. Okay, next we want to move on to the great vessels of the heart. As the video mentioned, we have the inferior vena cava and the superior vena cava. These are really these are the 2 main vessels that feed deoxygenated blood back into your right atrium for further circulation. And the inferior vena cava down here retrieves blood from the lower half of your body, while the superior vena cava retrieves blood from the upper half of your body. And as we already mentioned, the deoxygenated blood flows from your right atrium to your right ventricle and then gets passed to your lungs for oxygenation. As for the oxygenated blood flow, after it has the blood has been oxygenated by your lungs, it comes back into your left atrium, left ventricle, before finally exiting through the aorta, where it is then distributed to the rest of your body. Oh, and the vessels that carry oxygenated blood to the left side of your heart are the left and right pulmonary veins, shown here. They're sort of located on the posterior aspect of the heart, so it's a little bit hard to see in this picture. Okay, Moving right along to the internal structures of the heart, we wanted to talk about the valves. As I mentioned earlier, the valves here are sort of to prevent backflow of blood through your heart, because that would be bad and would cause a variety of issues. We have our tricuspid valve here, which is between the right atrium and the right ventricle. And as I mentioned, it's called tricuspid because it has 3 leaf slits here. And then we have your bicuspid valve, which exists between your left atrium and your left ventricle. And it's called bicuspid because it has 2 leaflets. And then finally, we have our pulmonary and aortic valves, which exist at your at the exit point to the aorta and your pulmonary artery, respectively. And we can see them here as well. And then these 2 pictures sort of illustrate the difference between the valves when they're closed. As you can see, it acts like a one-way door to prevent blood flow versus when they're open, which allows for free blood flow between the atria and the ventricles. Okay. Moving on to the internal structures, histologically, the main cell type is a cardiac myocyte, which we can see here. It is a striated muscle fiber, and it has a centrally located nucleus, and you can see the nuclei on these cells right here, these sort of dots. The cardiac myocytes make up the myocardium, which is the middlemost layer of the heart. And then the internal structures are also comprised of cardiac myocytes, and they include the pectinate muscles and the fossa ovalis in the atria, and the papillary muscles, the chordae tendineae, the trabeculae carneae, and the moderator band in the ventricles. And the histology section will talk a little bit more about these cells. I just wanted to give you a short overview here. Okay. Now, to focus a little bit more on the specific internal structures that I mentioned in the last slide, we have again, the pectinate muscles and the fossa ovalis in the atria. So we see the pectinate muscles here in the atria, and they really exist here to increase contraction force and act as structural support for your atria. And they're very noticeable. They're sort of parallel or vertical. And you can see the pectinate muscles here. And then finally, you have the fossa ovalis, which is this little hole in your heart here. It is the remnants of another structure called the foramen ovale, which essentially was important for blood flow in fetal development. But after you're born, it closes, and the only thing that's left of it is this little structure, the fossa ovalis. And then finally, in the ventricles, we have our papillary muscles, which are these bigger looking muscles here. They really act as muscles which keep the valve from reversing and preventing backflow of blood from the right ventricle into the right atria. And then the chordae tendineae, shown here, are attached to the papillary muscles and to the valves. And as the name suggests, they're thin and cord-like, and they sort of anchor the valves to the papillary muscle. And then finally, we have our trabeculae carneae here, which they are really just these thick layers of muscle in your ventricle, and they're just these muscular columns that help the functioning of the heart. And it's important to note that all of these internal structures are ensheathed by the endocardium, and that will be discussed later in the histology of the heart. Okay. Now, moving right along to blood supply of the heart, we're going to talk about oxygenated blood supply first. So when oxygenated blood is pumped out of your right ventricle into the aorta, it also feeds into sort of 2 main arteries that also provides blood supply to the heart, your LCA, or your left coronary artery, and your RCA, which is your right coronary artery. And then these also further divide into smaller arteries. So your LCA becomes your left anterior descending, or abbreviated LAD frequently. Also known as the anterior intraventricular artery. So left anterior descending and left intraventricular artery are the same thing. And then your circumflex artery. And then your right coronary artery becomes your posterior descending artery, or your posterior intraventricular artery. Again, these 2 names are interchangeable. And then you have your marginal branches. Okay. Taking a closer look at the blood supply of the heart, again, as I said, the right and the left coronary arteries arise from your aorta. So you can see them coming off of the aorta right here. And then, so your right coronary artery has your SA nodal artery, your right marginal artery, and your posterior descending artery. And they are shown right here. Here it's labeled as the posterior intraventricular artery. But as I just mentioned, this is the same as your posterior descending artery. And then for your left coronary artery, we have our left anterior descending artery, also known as your anterior intraventricular artery, and your circumflex branch, which sort of reaches around the heart here. As I mentioned, they originate from the aorta. And then it's important to note that these arteries form anastomosis, which are sort of interconnections between these arteries to provide other ways for blood to reach certain areas of the heart. Okay. And I wanted to take a step back here and talk about a heart attack or myocardial infarction. So as we know, the heart is a vital organ and it needs blood itself to function. And so a heart attack really arises when you have blockage of the arteries I discussed in the last slide, stopping the blood from reaching the heart and keeping it running. And blockage, like I said, if significant enough, can really cause chest pain or if it progresses to a heart attack. Okay. Moving along to the deoxygenated side of this, we have cardiac veins that carry deoxygenated blood to the heart, and there's really three main ones, and they run with their companion arteries. So we have your great cardiac vein, which runs with your left anterior descending artery, which is right here. So you see your great cardiac vein really follows the same path as your left anterior descending. You have your middle cardiac vein, which runs with posterior descending artery, again shown right here. And you can see that it really follows the path of your PDA. And then you have your small cardiac vein, which runs with the right marginal branch of your right coronary artery, which is right here. Okay. And then all three of these cardiac veins feed into your coronary sinus, shown here, which then finally drains directly back into the right atrium for further circulation. Okay. And yeah, that's everything I really had to cover today. Here are my references, and if anybody has any questions, I can take them now. Sure, Sammy.
Hi. So with this, with the myocardial infarction,
Mhm.
would this, would this would this be like kind of like a aortic, um, aortic? Wait, one sec. Sorry, a little nervous. Okay, would this be consistent with a like coronary occlusion? So I've seen it. I kind of seen it before because I did a little
Mhm.
interning in cardiology, but
Mhm.
in cardiothoracic. But so would murmurs, the different two murmurs, would that correlate with myocardial infarction, like mitral stenosis or aortic regurgitation?
Yeah,
Or
so the murmurs generally arise from, as you mentioned, aortic stenosis and like aortic regurgitation. That's not really an issue with blood flow to the heart. That's an issue with the valves itself.
okay,
So going back to the valves here, so aortic stenosis, and I think this is a little bit beyond what is needed for you guys right now, but just to touch on it quickly, aortic stenosis happens when you sort of have stiffening of these ventricles and it sort of stops blood from being pushed through from the atria to the ventricles. And sort of that turbulent blood flow is really what causes that murmur that you hear from your stethoscope. But that's sort of unrelated to blood flow of the heart
okay,
or blood flow supplying the heart.
okay.
Yeah.
Thank you.
Yeah, of course. Any other questions before I pass it off?
Dr. Peterson, maybe what you might describe in just a little bit more detail. I think the idea that the arteries, these coronary arteries, lie on the surface of the heart, but then we never really talk about their, blood is moving through them so quickly that that is not going to provide good oxygenation or nutrients to those cells. So that those have to have penetrating smaller vessels, arterioles, that become capillaries, and then it's just an incredible, vast network of capillaries. And I think Austin will probably touch on this, where the gas exchange is actually happening side by side with those cardiac myocytes. And once that oxygen has been removed, it's replaced with the deoxygenated blood. So now we kind of have a backward kind of tree. So the venules then are coming up from that middlemost layer and then back into the veins and then draining back towards the right side of the heart. And I think, explaining that, or at least letting students know that that's the other part of the story, kind of makes everything make more sense.
Thank you, Dr. Peterson.
And there's a question in the chat. Kyle, can you see that?
I don't think I can see the chat from where I am here.
Just asking, are there any other symptoms of myocardial infarction other than chest pain?
Yeah, so chest pain, and then of course, if your heart is not pumping blood, right, you would really have a bunch of other associated symptoms such as shortness of breath. And so shortness of breath, you would start sweating, you would feel really uncomfortable because of course, the heart really oxygenates the rest of your body. And then, so if you all of a sudden stop blood flow to the rest of your body, eventually your organs would start shutting down, and a bunch of really unwanted symptoms, but really the most sort of pressing ones that you can use to get an idea or a feel that it's going to be a myocardial infarction would be chest pain, shortness of breath, fever, or not fever, sorry, sweating.
Kyle, can you
Oops,
just
sorry.
explain to everybody, because I'm sure everyone knows someone that has had chest pains before, that that symptomology is not always the case, especially in women. Do you just want to elaborate a little bit on that?
Right. So your chest pain can come from a bunch of different things, and they really have a bunch of different words to categorize the chest pain, such as like pleuritic chest pain and a bunch of different like qualifiers for the chest pain, as we know. So sort of in your heart or like in the thoracic cavity area, there's also your lungs. There's also different muscles. So really you can have chest pain that is sort of not from your heart, but you can have pain sort of from the muscles. You can have pain from your lungs, or something going on with your lungs. And again, chest pain. So myocardial infarction is actually the most severe version of this occlusion of the arteries. There's less severe versions where the vessels are only partly occluded, and that is not necessarily indicative of myocardial infarction. It's really just indicative of the inability of your heart to sort of fully oxygenate itself.
And then it looks like Sammy has his hand raised and has a question. So go ahead, Sammy.
Sure.
Hey, yes. So would there also be symptoms? I do like how you did add the coronary occlusion, because I was going to ask that. But what are common causes or similar symptoms? Would it be like JVD or dyspnea, hypoxia, all that? Would that be common in a
It
myocardial
definitely
infarction?
Right, it definitely can be seen. So JVD occurs when sort of you have backup of blood flow. And so your jugular vein, right, is a vein. And so it's one of the veins that feed deoxygenated blood into your heart. So a myocardial infarction really leads to the death of cardiac tissue. And because of that, you would really have backflow, or not backflow, but like congestion. And if that occurs for long enough, you definitely would get JVD, because then your backflow would affect all the way back into your veins, and you would have more accumulation of blood in the different veins, causing things like jugular venous distension and also edema. And then shortness of breath, dyspnea, of course, because again, your cardiac system and your pulmonary system is very intimately connected, and they sort of function together to provide oxygen to your heart. So if you have dysfunction with your heart, that would also cause that backup of fluid into your lungs, causing dyspnea. And then hypoxia, right? Again, hypoxia, you want your body to be oxygenated. And if the organ that is supplying that oxygenation no longer is functioning or functions at a suboptimal level, yeah, you would not be able to oxygenate your blood and the rest of your body as efficiently, leading to hypoxia as well. And then that can eventually progress to things like shock, where your organs really start failing because they're just not getting enough oxygen.
Right. Right. So that would also, I have seen like during like my internship, I have also seen similar things to like what was it? What was it? What was it? I know you did. It was something. Mona. That's what it's called. I learned Mona. Oh my goodness. They bashed that into my. So they did say Mona. So I think it's let me think. Morphine. Morphine. I think aspirin, or either it was an aspirin. I think. Oxygen, and was it anti-epileptic therapy? I think.
Nitroglycerin, I believe.
Thinking nitrates.
Yeah.
Nitroglycerin.
Yeah. Nitrate.
Yeah. And so, again, this is really outside of the scope of what you guys are learning now, but yeah, I could touch that. No problem. I love it when people ask questions like that, because, we just learned about it as well. And so Mona is really the sort of the first line, or like the first reaction you get if somebody has some sort of cardiac problem, like a heart attack. And so the morphine is really to help for the pain. Right. The oxygen is because, as you mentioned, we have hypoxia. So we want to maximize the oxygen getting into your body, because to compensate for that decreased ability to sort of provide oxygen to the rest of the body, right? Nitrates are vasodilators. And so, so you want to open the blood flow. And sort of, I believe it also dilates the coronary arteries to try to get a little bit more blood flow through those occluded arteries. And then aspirin is really an antiplatelet. So what that does is it stops the blood from clotting. And sort of, if you have a blood clot, it could further occlude the artery, because really a clot is just like a blockage of those arteries. So you really give it an platelet to basically allow the blood to thin itself a little bit more, so that it can flow more smoothly through the arteries and the rest of the body.
Okay. And my final question. So I understand that there is Mona, there's the ABCDE method, the antiplatelet therapy, blood pressure control, cholesterol, diet modification, and diabetes and exercise. So would you use Mona in that for a myocardial infarction, or?
So Mona is really like it's emergent. Like that's what you give when somebody is actively having a cardiac issue, right? It's like he just came into the emergency room with a heart attack. These are the things that we're going to give him that sort of almost immediately try to make him feel better. The ABCD method is more of like a long-term thing from what it sounds like, for example, diet, right? And cholesterol. So cholesterol is really what builds up in your arteries to cause that occlusion right here, the blockage, right? A lot of the times, if you sort of take this part of the vessel and you really look at it under a microscope, you'll see that it's a buildup of cholesterol. And so really sort of reducing your intake of cholesterol or reducing the amount of cholesterol in your blood is how you prevent this blockage or future blockages from occurring in the first place. And then, of course, that comes with diet modification, right? If you're eating foods that are really, really high in cholesterol, you're supplying your body with more cholesterol, and that really increases the chances of that happening. So it sounds like the ABCDE method is more sort of like a long-term preventative thing to stop myocardial infarctions from happening or other vessel occlusions from happening, whereas MONA is really sort of that first line knee-jerk reaction you do when somebody comes in with an acute coronary issue.
Okay. Yeah, thank you, because the case that I seen, the patient, oh my goodness, they did have all of that stuff. Like they came to the resuscitation bay. They did non-rebreather mask. They did Mona. The patient was experiencing diaphoretic dyspnea, dysphagia, hypoxia, all that good stuff. And so I just, I didn't know, like, I only stayed for like all that good split seconds, and then I had to go back to another round, but I just had a question of those. So thank you.
Yeah, of course. Of course. And thank you for asking these questions. Gives me opportunity to see how much I remember from my cardiac block.
You did great, Kyle. Thank you.
Yes, you did good.
Of course. And with that, I will pass it off. Thank you so much for letting me be here and share a little bit about cardiac anatomy today.
All right. Okay, well then our next section will be on histology of the cardiac and circulatory system. So our next presenter is Austin Boehm. Austin is from Millbrook, Alabama, and graduated from Auburn University at Montgomery, majoring in biology pre-health. He is currently a second year at Edward Via College of Osteopathic Medicine in Auburn. Outside of school, Austin enjoys gymnastics, parkour, which is the sport of traveling or traversing environmental obstacles by running, climbing, or leaping rapidly and efficiently, and all types of related acrobatic activities. Austin's favorite part of anatomy being able to apply it to physiology to make sense of how the body functions. So,
all right, thank you so much. Again, hello everybody. My name is Austin, and I'm going to be talking to you guys about histology. So let me get my screen share up. And can everybody see this? All right. So histology of the cardiac and circulatory system. Before we get in too much to the details of this, there's a little overview here, but you guys just went over the anatomy, so I'm not going to belabor that point. I'd like to start off with a little bit of vocabulary question type of stuff, just to get a gauge for some of the terminology that you guys are familiar with. So we're just going to do a quick poll and get your thoughts on this question here. So the question is, which of the following refers to a membrane that is directly in contact with the organ that it's covering?
All right, and get your answers in, folks. I'll be closing the poll in 5, 4, 3, 2, 1.
All right, so it looks like you guys did pretty good on that one. The correct answer is visceral. So visceral is referring to kind of the viscera, the organs, which are the internal structures. And whenever something is directly touching one of the organs, that's referred to as something visceral. Parietal refers to something that's kind of on the outer body wall, more of a perimeter. Deep and superficial are just levels of at the skin, deep to the skin. And then fascial is just kind of that layer that's over everything internally. But that's good that you guys are somewhat familiar with those terms for the most part. As for today, our learning objectives, we're just going to be trying to describe the structural composition of the 3 histological layers of a typical blood vessel, which are referred to as the tunics. And then we're also going to be identifying the histological features of 3 layers of the heart, which are the endo, myo, and epicardium, and then talk about some of their functions. So you guys just went over the anatomy of the heart. This is just another picture of what that would look like on histology. So with the histology of cardiac tissue, there's some differences with the cardiac tissue compared to skeletal and smooth muscle. So before I get too much into those other ones, the main things that you'll see with cardiac here are the intercalated discs. That's kind of a noteworthy thing that you'll see with them. They're kind of these vertical stripes that kind of separate those cells out. They've got centrally located nuclei here, which you can see in this cartoon and then also on the real one. And they kind of branch out into these Y-shaped patterns. So one of our professors would always stand out in front of the class and he'd stick one leg out and bring his arms to the side like a Y. And that's how their branching pattern is. They look like a bunch of Ys kind of splitting and forking in the road there. Now, before I get into details about all the differences, I wanted to ask another question. I'm a big fan of questions to get a gauge for what you guys think. And because I know if I ever miss a question, I always remember that better than if I just hear something the first time. So this time, which of the following correctly describes a difference between cardiac muscle and skeletal muscles?
All right, get your answers in. I'll be closing the poll in do 5, 4, 3, 2, 1.
So there's a pretty good split of answers, but a few of you guys were clued into this one. So one difference between the cardiac muscle and skeletal muscle is that the cardiac muscle is branched, skeletal muscle is not branched. So right here we have kind of 3 different types of muscle tissues that you can see histologically and some of the defining features. I tried to highlight some of the main ones that I like to use to tell them apart, or the things that kind of stand out to me. The main one with cardiac muscle is that it's branched, whereas none of the other ones are branched. Skeletal muscle is kind of straight tubes. This picture almost makes it look like it's kind of branching, but you can't follow it, and that's most likely just because they kind of got a diagonal section through the tissue when they took that. But that's going to be tubular, straight, and peripheral nuclei for skeletal muscle, whereas the cardiac muscle is uninuclear, and it's got those central nuclei as well as branching patterns. Smooth muscle, on the other hand, can almost start to look like the cardiac muscle. However, it's just got this wavy, spindled appearance, and that's the main thing, as well as none of those intercalated discs in the cardiac muscle. All right, now moving on to the actual heart itself and the different layers. We're going to be talking about those going from superficial to deep, starting with the epicardium, which is out here kind of on the surface, and then we're going to move our way in through the myocardium and then endocardium. So here's a section of the heart, and this is a kind of up-down section. You can think of that as either a sagittal or a coronal. it doesn't matter too much because we can see the 3 layers here. Starting with the epicardium, that's also called the visceral pericardium. So something that I think was mentioned in the anatomy section was there's the visceral and the parietal pericardium. The visceral pericardium is actually the same thing as the epicardium. That's just another name for it. And that's on the most superficial surface of the heart, which is composed of simple squamous epithelium, which is just kind of a very thin layer of cells that might be this out here. There may be some artifacts with how this section was done. But one of the most important things to do with the epicardium is that's where the coronary blood vessels are located. So those things that we were just talking about, the last little section was those the LAD, the right coronary artery, those are going to be located within the epicardium. Now, moving down, the next layer is the myocardium, and myo stands for muscle. So that's where the muscle is going to be. It's that thick pink layer that you can see here. It's the thickest layer, and that's what's going to have those cardiomyocytes or the cardiac muscle cells. And then it also has a little bit of collagen and then blood vessels and nerves, because ultimately, while the main blood vessels are out in the epicardium, those little small branches that have to penetrate and supply the tissue that has the greatest oxygen demand are going to be going to this spot. So that's why there's also blood vessels and nerves going here. And those nerves are going to be what helps control whether your heart's going to be pumping faster or slower, stronger or weaker, and those types of things. And the last layer on the inside, you probably can't even see it. It's just a very thin, again, simple squamous epithelium layer, which is just single flat cells that look kind of like fried eggs that would be sitting out here. And that's what's on the innermost layer of the heart, kind of making contact with the blood that goes through those different chambers. And it lines those chambers and the internal structures, which is also going to be those the papillary muscles and all those types of things, which I believe this P here is little papillary muscles. And it's also got some, it's also called the endothelial cells. That's another name for those that you may see, which is going to be continuous with the greater vessels that branch out of the heart and go into veins and those types of things. All right, so now that we've just gone over the different layers, I've got another question here. It's a little bit long, but essentially a patient is suffering from a condition known as systolic congestive heart failure, and systolic is that contracting phase of the heart. And it has an inability to properly contract, which leads to a reduced ejection fraction, causing an inability to pump out enough blood to meet the body's demands. Which of the following histological layers would you expect to find pathological changes?
All right, I'm seeing some good participation on this one. We're going to go ahead and close the poll for this one in 5, 4, 3, 2, 1.
All right, so we had a pretty even split there, which is good because that means it's an opportunity to explain things a little more and make sure that that's clear. So the correct answer here is myocardium. And the reason for that, that I was trying to get at with this question is there's a systolic failure. The heart isn't able to contract, and those contractile cells are going to be the muscles. So what happens in this condition is the heart kind of stretches out like a balloon, and there's going to be a weakening of the muscle cells, which are going to be located in the myocardium. So if you have an issue where the heart is unable to pump, it's weak, and it can't meet the body's demands, that's going to be an issue with the myocardium that you would see. You could argue that it could be caused by an occlusion of some arteries, But that wouldn't present as congestive heart failure immediately. Congestive heart failure is kind of a chronic thing that can be due to multiple factors rather than just occlusion of an artery or something like that. So now that we've touched on the heart and the different layers, we can get into the blood vessels, starting from the aorta, going all the way around into vena cava. So the main things that you want to look for when you're looking at arteries versus veins, and you can see a good one in this picture, just kind of as a rule of thumb, the veins will usually kind of flatten out and have a more squiggly overall appearance of their lumen because they're weaker, they're not as strong, whereas the arteries are circular, they hold that shape pretty firm even if there's pressure, and then they have this thick layer here in the middle that has a lot of muscle in it, whereas the veins, you don't really see so much of that thick layer. There's a little bit, but the rest is more on the periphery there. So for those different layers, again here, arteries, thicker walls, the tunica media here is where it's going to be thickest. Veins, on the other hand, the tunica externa is going to be thickest. They've got valves as well, but arteries and veins, arteries away, and then veins always go towards the heart. And that's how I keep it straight because, like that exception that was mentioned in the last hour, arteries aren't always oxygenated if it's right coming out of the heart, going to the pulmonary system. So there are 3 tunics from inside to outside in the blood vessels, which are the tunica intima, the tunica media, and the tunica externa. The names make sense. Intima is kind of intimate on the inside, media in the middle, and then externa on the outside. Now, here on the left and then on the right are 2 pictures of vessels. The left side is going to be an artery, and then the right side is going to be a vein. So the tunica intima is up here, this more superficial layer. And that is a series of squamous epithelial cells, those endothelial cells that are the same ones that are lining the endocardium inside the heart. It has an internal elastic membrane here that separates it from the next layer down. And that can be seen a little bit easier here on maybe the vein, but it's right there on the artery. And then one important thing in the peripheral arteries with the tunica intima is that it's what releases the endothelins, which can constrict smooth muscles when you want to increase blood pressure in the vessel wall. So a good example of that would be if there were injury here, those endothelins would get released. They're kind of contained inside it, and that could lead to some vasoconstriction to try to stop the bleeding.
If I can interject, Austin, really quick, I just want to
Yes.
clarify one thing you said is the tunica intima will be technically the deepest layer when we're talking about coming superficial always on the outside of the body and then deepest on the inside. It looks on these cross sections always like it's the most superficial because we're seeing it without any tissue deeper to that. But this section is looking at, if you could go back maybe one more slide and maybe kind of just draw a little outline with where approximately we're looking at, like a little box. And that can help them understand kind of how that is the deepest layer.
Okay, here we go. So what we're looking at with the tunica intima is right here, which is going to be where your blood is. Your blood is in this hole right here. That's where the blood cells are going to be flowing through. And the tunica intima is closest to where the blood cells are flowing through in that vessel. And so when we come over to here, oh, and my drawings are still there. I got to erase those. There we go. So when we come over here, this up at the top is what we were just looking at on the other side. So there would be blood that would be flowing through kind of the top of this section here. So the layer in the middle is the tunica media, and that is where all of the smooth muscle cells are. If you'll notice, that's kind of similar to how it was in the heart itself. And again, on either side, it has that elastic membrane. There's an external and an internal one in relation to where the blood is going to be. And something called the vasa vasorum is what nourishes this. And the vasa vasorum is essentially just the blood supply to the blood supply. It's going to be the blood that is going to these muscles to make sure that they have enough oxygen to be able to do their job. And the most important thing with the tunica media is that it is what is responsible for the contraction or the relaxation of your blood vessels. So very important in regulating blood pressure in the periphery, because it's one thing to change how much blood you're pumping through the heart, but it's another thing to change how that's getting around through the periphery, whether that be redirecting blood flow away from your gut if you're exercising and putting it to your muscles, or vice versa, and that type of thing. And one more thing is that it is the thickest in arteries here. You'll notice it takes up kind of a big majority of that, whereas in the veins, it's maybe about a third of it. It's not quite so significant. And then the most external layer, the tunica externa, away from where the blood is going to be flowing, is going to be out here. It's also called the tunica adventitia, so that's why it's labeled as an A here. And it is what has the fibrocytes, which are cells that secrete collagen, and that's what kind of anchors the vessel down and keeps them from wiggling around too much. That's also where the vasa vasorum is going to be mostly residing, and then giving off its branches that go inside. And the thing to note about that is when you're looking at veins, the tunica externa is going to be that biggest section here, whereas on the arteries, it's really a pretty small section of them. All right, and I've got one more question here, which is, during the acute injury phase after a blood vessel is torn, endothelins are released to cause vasoconstriction in order to decrease bleeding. Which type of cell, when damaged, releases these chemicals into the blood?
Good job again, everyone, for putting your answers in. We will close the poll in 5, 4, 3, 2, 1.
All right, so the correct answer for this one is going to be squamous epithelial cells. And so the reason for that is because when blood vessels are torn, endothelins are released from the tunica intima, that most internal layer, and that is composed of squamous epithelial cells. So those are the things that when they get damaged are going to be releasing the endothelins, which is a signal that, hey, there's some damage, something has gone wrong. We're going to constrict and try to limit the damage. Cardiomyocytes are the heart muscle cells, and so those are going to be located in the heart. Smooth muscle cells are going to be in the tunica media, and those are just the contractile ones that are actually going to be responding to the endothelins, and they're going to be doing the constricting. Fibrocytes in the tunica externa are kind of just those anchors, and then I just threw in some other random word here. All right, but in summary, some of the things we've covered as they pertain to the lesson objectives. The blood vessels have 3 layers from internal to external, internal being where the blood is flowing through. That's the tunica intima with the epithelial cells responding to damage. The tunica media that has the smooth muscle cells allowing for the peripheral regulation of blood pressure. The tunica externa has fibrocytes, which produce the collagen to anchor those vessels. And in arteries, you can look out for the tunica media being the thickest, which is going to be that big pink section. Whereas in veins, the tunica externa is going to be larger, and that's a little bit paler. As for the heart, there's another 3 layers, very similar, but these are more talked about from external to internal, meaning more superficially. The epicardium has simple squamous adipocytes with some fat and the coronary arteries, which is important. The myocardium is that thick layer with all the cardiac muscle cells that's responsible for the function of the heart and pumping all the blood. And then endocardium has simple squamous epithelium, again, similar to the epicardium. That's what's lining the inside of the heart chambers, and that's kind of the same simple squamous epithelium that's out here in the tunica intima. There's some references. And do you guys have any questions about that?
I think we always tend to get a little bit quieter when it comes to the questions for histology and embryology. Sometimes that could just be of, needing a minute to sit with the information that's there so far, but feel free to ask again, Austin or Kyle, any questions at this point about our, their experience in medical school or what they're learning there. Any of those things I think would be applicable, and we'll still have plenty of time to move on to our next presenter.
We
Sammy, I
actually have
see you've
a
got your hand
question.
up.
Sammy, please.
Yes. Do you have any like mnemonic ways that we can remember all this? I mean, you gave us some good ones, but do you have any more maybe?
Okay.
Share
Mnemonic
your secrets.
for any secrets for remembering these types of things? With these, it's not so much mnemonics. It's mostly just understanding what the meaning of the words is. So intima kind of on the inside, media in the middle, externa on the outside, and then epi kind of means upon, more superficially on the surface. Myo means muscle, and it also sounds like middle because it starts with an M. And then endo is on the inside. And I think that the function is kind of similar to that with the tunica intima and then the epicardium and endocardium. They're kind of just layers of cells there that act as walls, kind of sandwiching the muscles in the middle. And then arteries having more muscles makes sense intuitively when you learn more about how the arteries function, that they need to have contractility to be able to move the blood, whereas veins are kind of just the blood is flowing and pooling and getting through those one-way valves. So they don't really need to have those muscles to contract quite as much as the arteries do. The arterial system is also a higher pressure system, which is another reason why the arteries need to have a bigger tunica media, because especially like around the aorta, that's really, really high pressure. And so it needs to be really big, strong, and have thick muscles to be able to keep all that blood in. Whereas if you maybe had that much pressure at the vena cava, it might start to tear and damage that a little bit more because it doesn't have quite the bulk and the muscle to keep that contained. So as you work through this material, I think it comes more intuitively as you get a more complete understanding rather than having like mnemonics for certain types of things, unless there's a specific like type of thing that you're having difficulty remembering.
But Austin, Dr. Frank put a kind of snappy one in the chat. So this would be a mnemonic for the layers of the blood vessel. So Lima. So from the lumen, then next would be our deepest layer, the intima, then the media, and then the adventitia. And I have never seen that before. So kudos, Dr. Frank. Thanks for sharing that.
You're welcome. We have a question from Pranil. Does oxygenated or deoxygenated blood affect how these three tunic cells function?
I'm gonna ask for a little clarification. Do you mean like whether it's an artery versus a vein, does that affect how it functions, what it's carrying on the inside? I think that's what you're getting at. And if that is what you mean, the function of them is honestly not that different. Even when the veins are torn and injured, they're still going to want to contract what little bit they can to try to stop the bleeding. Although veins, again, they're a lower pressure system. So if you do kind of break a vein or rupture a vein, it's not going to be losing as much blood as arteries would, because arteries are a much higher pressure system. So they really need to have that quick snap reaction to, okay, we need to stop the flow. Whereas veins, it's kind of like having a drippy faucet on your sink. That's not an immediate problem. Whereas arteries, if you rupture an artery, that's like your toilet starts flooding over. You need to get that fixed immediately. So the individual cells and the different layers still do the same function. It's just in the veins, there's a little bit less of an importance on the tunica media and muscles, which is kind of the main difference between arteries and veins.
And maybe
Okay,
Austin, just sharing with everybody that's on the call and as we're recording this, just what a tunic actually represents. I always think of it as like a layer of clothing. So just want to make sure that everyone understands these layers that are making up the wall of the blood vessel. It's the layers that are really made up of these sheets of cells that are then forming the tube. So I think that's really important. And Austin, I just wanted to say thank you so much. You did an awesome job tonight. Thank you.
Thank you. Yeah. And like you were just saying, kind of if you're wrapping yourself in clothing, these tunics here, kind of in the middle, you can think of, I guess, the body would be the blood where all that is located. And then you've got your different layers. So you've got your intima, which is kind of the undershirt that's under what you're wearing. The tunica media is going to be maybe your button-up shirt that you're wearing. And then the tunica externa is the suit jacket that you've got at the end. So you've got those three layers kind of doing different things, but they're all together, all covering the same and making up the same outfit of the blood vessels.
good analogy. Nice.
But I guess if there's no more questions, I'll pass it on.
All right. Well, I don't think there are any more questions at this point, so we'll move on to our final segment. So the next and final segment is on embryology of the cardiovascular system. And tonight we have Kyle Yu with us. So Kyle is originally from St. Louis, Missouri, but then moved to Seattle, Washington, where he finished high school and graduated from the University of Washington in 2022, majoring in chemistry and biochemistry. He is currently a second-year medical student at Sidney Kimmel Medical College at Thomas Jefferson University with an interest in anesthesiology or physical medicine and rehabilitation, also known as PM&R. In his free time, Kyle enjoys playing badminton, cooking, or enjoying the outdoors. So with that, our second Kyle Y, the floor is yours.
All right. Hi, everyone. As Dr. Frank said, I am the other Kyle Y tonight. Share my screen. All right. Can everyone see that? All right. Great. So my presentation today is going to be covering cardiovascular embryology. So here are the learning objectives today. Let me cursor. All right, so first of all, we'll just kind of take a big picture overview and kind of go back to a couple weeks ago when we learned about gastrulation, like the germ layers, and kind of orient ourselves in terms of where the heart comes from. So the heart comes from the splanchnic mesoderm, and then just to recall, splanchnic just kind of refers to the cardiac and smooth muscle target cells. So it's kind of the big picture overview of where the hearts and all its derivatives are coming from. All right, so first we're going to discuss heart fields. So there are two heart fields, primary and secondary. So the primary heart field develops into the initial tube, and then this will form the atrium, the two left and right atrium, as well as the left ventricle. And this starts developing on week 3. And then the cardiac crescent, which kind of develops on the periphery of the mesoderm around day 15. And then that kind of forms like a little crescent, like a little horseshoe type region. And then with some folding and some manipulation, it kind of forms these tubes that you see here. right? And then this has an inflow region, which will eventually become your vena cava and your atria, and you have your outflow region, which will eventually become your truncus arteriosus. And we'll get into this a little bit more in the next few slides, but I think something to point out here is that these are kind of flipped from the way you think. Like the outflow regions are kind of on top, and then the inflow regions are kind of on bottom. And remember, this is kind of cranial referring to embryologically like toward the head, and then caudal, which is down here, referring to like away from the head. All right. So at day 21, you kind of have the fusion of these two endocardial tubes into one big structure, and this is also when the heart actually starts to beat in the fetus. And then we have this primitive heart tube, and then we have these primitive derivatives, which I'll get into in a sec. All right, so this is kind of now a cross-sectional view of the heart tube, and I'm just going to go over the layers. So, and we have the heart tube. In the innermost layer, we have the endocardium, which is a simple squamous epithelium. Remember, that's kind of like the innermost layer that's kind of like lining the inside of the heart. Just outside that is the basement membrane and cardiac jelly, which is basically a gelatinous matrix and gelatinous like mix of like fibroblasts, collagen, stuff like that. Kind of allows we will have some of it plays an important role in the development of the heart, and kind of there's some precursor stuff in there. Next, we have the myocardium. Just go back what Austin said, that's where the cardiac muscle lives. And then outside we have yeah, and going outside with the pericardial sac, like the other Kyle mentioned, this is kind of the sac that surrounds the heart and kind of allows the heart's like room in the thoracic cavity to kind of expand and contract as it's pumping blood. Right. So the secondary heart field now, that is what's responsible for kind of elongating the tube and then initiating like the looping of the tube. Remember, so we're going from this like linear, like tubular structure, and then we're kind of like now we have to bring it to like kind of the asymmetric shape that it has in a fully developed heart. And so, as you kind of notice, like there's a lot of asymmetry with the heart if you kind of look at it, look on diagrams and stuff like that. And what's responsible for that is because the ventricle kind of grows out much more quickly than the atrium. And that's also represented in the actual like size of the atrium versus the ventricles on either side. And this kind of just pushes the heart out into like your chest and causes that asymmetry. And then here, I'm just going to show a quick video on the folding of the heart tube, because it can be hard to kind of just visualize just with words. So you can see here, it's kind of making this characteristic S shape as it's in the middle of the looping process. I think kind of going back just a little bit, you can kind of see like this is kind of where the bottom of the heart tube came, and you kind of see that kind of goes a little bit backwards to kind of where your atrium are. They're a little bit more posterior relative to your ventricles. And then here you have your truncus arteriosus, which will eventually become your aorta and pulmonary vessels. Those kind of go a little bit more forward relative to the tube, and then a little bit more superior. And that's kind of, you can kind of see where that's kind of where it ends up in the fully developed heart. All right. All right, so here's kind of like I kind of alluded to this, kind of, we have all these terminology of the primitive heart tube, kind of what do these actually become? So the truncus arteriosus, aka the outflow tracts, this will become the pulmonary trunk in the aorta in the adult. The bulbus cordis will become the right ventricle. The primitive atrium will become the right and left atria. The primitive ventricle will become the left ventricle. And then the sinus venosus is kind of incorporated in the back wall of the right atrium, kind of where the vena cava kind of merged together, kind of fused together into the heart. Right. So this slide is going to show like the kind of the borders and like the borders between like the primitive regions of the heart tube, kind of on a fully developed heart. So here, like I said, this is the vena cava and the right atrium, and this is from the sinus venosus. And then here you have the pectinate muscles, which are kind of the muscles that line the right atrium. And these are from the primitive atrium. And then there's this feature called the crista terminalis, which is this kind of ridge that kind of separates the smooth and muscular portions of, or the these pectinate muscles in the region. So very cool to see again in the dissected heart. And here we have the ventricle. So this is kind of like this is the trabeculate carne, which is kind of like the striated portions of the ventricle. This is from the bulbous cordis. And then you have the beginning of the pulmonary outflow tract. This is coming from the truncus arteriosus. We'll go into a little more in terms of the ventricular septation, but you kind of see it goes from muscular to this smooth portion. And then we'll get to that also in a little bit. All right. So my first question is which adult structure came from the most cranial embryologic region of the heart tube?
All right, and get your final answers in because the poll will close in 5, 4, 3, 2, 1.
I spoiled it a little bit on accident because I touched my mouse, but the correct answer would be the pulmonary trunks. Remember, you have the truncus arteriosus. That's the most cranial structures. This is the cranial region. This is the caudal region. And the truncus arteriosus will become the pulmonary trunk. A common answer that I saw was also the aortic valve, and that's kind of I will get to this a little bit later, but the aortic valve is not formed from kind of these structures. It's kind of another structure that's kind of formed later, and I'll also talk about that. But if question A said aorta, then there would technically be 2 correct answers because they both come from the truncus arteriosus, which is the most cranial embryologic feature of the heart tube. Right. So now, how we have this heart tube, how do we have left and right ventricles and left and right atriums? How do we have all these septations? So first, we'll talk about the endocardial cushion. So the endocardial cushion is kind of this progenitor region with like lots of fibroblasts, and they produce a lot of connective tissue. And I kind of like to think of it as kind of like the anchor point of all the internal development of the heart. And I'll kind of touch back on this in a little bit. And then again, so the tissues from the cardiac jelly form the fibroskeleton, the heart, and the valves. The arteriovenous valves of the heart. Which will separate the atrium from the ventricles. So you kind of see, so this is a cross section of the heart tube. So kind of you have these endocardial cushions. They're kind of producing more cells, and they kind of pinch off right here, and then you form the left and right AV canal. So with the right canal, you'd have the tricuspid valve. With the left, you'd have the mitral valve or the bicuspid valve, and then that's how you have formation of that. And again, that's how you form the septation between your atrium and your ventricles. All right. So next we're going to go into the interatrial septation. And I have to shout out Emmeline Whitwer, who gave this presentation last year for making these drawings, because these are a really great demonstration of how the atrium or the septums form. All right, so first, here's the endocardial cushions, kind of again, like I said, it's kind of like I kind of think of it as an anchor point for the internal development. So first you have your septum primum, septum meaning like the division, and then primum meaning the first. So this kind of grows down from the floor of the primitive atrium, and then this forms what's called a foramen primum, foramen meaning opening or hole. And again, primum first, so this is the first hole basically of the atrial septation. And then next, what happens is that as this septum primum is growing down, you actually lose some cells in the top, and this is what's known as the foramen secundum. So it's the second hole, basically, of the atrial septation. All right, next you have the septum primum kind of grows all the way down to the endocardial cushion, and then what remains is just that foramen secundum, and then this is kind of the flow of blood in the heart. And lastly, we have the development of the septum secundum, which kind of comes from both the endocardial cushion and the wall of the atrium. And then this kind of forms together and then kind of partially covers the foramen secundum, which is now named the foramen ovale. And then you can kind of refer to this like the original like septum primum actually acts like a valve. Kind of if you have like a lot of blood, if the blood is flowing, you'll kind of push that valve open. If there isn't any blood, then it'll kind of keep it closed. And that's kind of a very like a big part of the fetal circulation, which won't be covered too much in here, but we cover a lot more with the regional objectives. All right, so this slide just has all the steps just kind of in one picture for your reference. All right. And then one small thing I want to point out about the foramen ovale. So the foramen ovale in the fully developed heart, it leaves a remnant, what's called the fossa ovalis. And as you can kind of see, it's kind of strategically placed because in the fetal heart, you have the majority of your blood flow comes from your inferior vena cava as it comes from the mom. So then the foramen ovale is kind of positioned in a way that the blood flow can just maximally hit this region and be able to go through the foramen ovale as part of fetal circulation. All right, next we're going to go over the interventricular septum, which is a lot easier than the atrial septation. So the interventricular septum has two components, a membranous and a muscular septum. The membranous portion kind of arises from endocardial cushion. So remember this pink region represents the endocardial cushion, as well as some formation of the neural crest as the spiralization of the outflow tracts. It kind of all merge together to form the membranous portion. And then secondly, we have the muscular portion, and that just kind of arises from the floor of the primitive ventricle. It kind of grows upwards. All right, so this is just kind of a diagram of the final product of septation. So here we have the inner atrial septum. This, I believe, is the fossa ovalis, and then here we have the interventricular septum. You can see the like membranous portion here. You can see the muscular portion, and also just kind of orient yourself because we're kind of tilted. This is your right atrium. These are your superior vena cava, inferior vena cava, left atrium, left ventricle, right ventricle. All right. So the second question I have is, which of the following is not fully derived from the mesoderm/myocardium?
All right, and the poll will close in 5, 4, 3, 2, 1.
All right, so the correct answer was the membranous interventricular septum. So the membranous ventricular septum has contributions from the neural crest cells, which come from the ectoderm, and we'll touch a lot more on this when we talk about the spiral septation of the outflow tracts. But everything else kind of does come from within the mesoderm. It's just kind of this is the one big exception of terms of outside the mesoderm in relation to like how the heart develops.
Hey, Kyle, before you move on to that, Dr. Peterson, maybe you could just go back to explaining again the significance of that foramen ovale and why an embryonic heart, why it wants to move that blood over to the opposite chamber, and just highlight, hey, oxygenation isn't happening in the lungs yet, so we're not sending a lot of that blood that way. I think that would be really helppful for the students that are watching this.
Yeah, I wish I had like a better, because fetal circulation I know was more covered by the regional, so I wish I had a photo would really help. But basically, the lungs don't fully develop until much later in the in a pregnancy, basically. So the heart develops pretty early because the heart, I think it's one of the first things that actually develops and is like fully functioning organ. And then the lungs don't develop too much later. So basically what happens is that since you have basically your lungs aren't developing, your body is basically saying you don't want to send blood there. So remember, coming back to anatomy, right, we have the blood that comes back from the vena cava, it goes into the right atrium, right ventricle, and then that gets pumped out um, through the pulmonary arteries to the lungs, right? And then the left ventricle, you get fresh blood from um, the lungs, and then that gets pushed out like left atrium, left ventricle, out to the aorta, and out to the rest of the body. Basically, in the fetal heart, since the lungs they're not functioning quite yet. So basically what happens is that you want to send blood over to the left side to get pumped out to the aorta because you have all your oxygenated blood from the mother and from the umbilical vein. And so basically the whole point of the foraminal valley is to let blood go from the right atrium to the left atrium, so you have the oxygenated blood is able to get pumped out to the rest of the body. And then you have very little blood flow actually going through the pulmonary trunk at an early stage in development. All right. All right. So next, so again, a little bit back to the cardiac jelly. So the endocardial cushions contribute to the formation of all the valves as well as the intramembranous portion of the interventricular septum. So again, here we have this is kind of a cross-sectional view, the two AV valves, and then here are the two valves of the outflow tracts, the aortic valve and the pulmonic valve. All right, so now we have the atria and the ventricles formed, but then now we have to look at how the actual outflow tracts of the two ventricles are formed. So basically, how do we get from here to here? All right, so spiralization so the outflow tracts actually the septum actually forms a spiral. And this is formed in the truncus arteriosus. And again, like I said earlier, this is due to the migration of neural crest cells into the truncus arteriosus. So here we have a diagram here showing the flow of blood. So here we have the deoxygenated blood that's flowing through the pulmonary trunk is going this way, and then the oxygenated blood from the lungs is getting pumped out through the aorta, through the aortic trunk here. And so basically how this forms is that early on in the truncus arteriosus, you have these two ridges that form here, and they basically grow downwards back towards the heart, and then they kind of twist and form a spiral as they kind of make their way down, kind of demonstrated in this diagram right here. So basically, eventually these will go all the way down, and they'll meet up with the membranous portion of the interventricular septum that again come from the endocardial cushions. And then that kind of forms your entirety of the membranous portion of your interventricular septum, which is why there's a lot of parts, moving parts in terms of the membranous portion of the interventricular septum. Yeah, and then in a manner similar to the formation of heart valves, the neural crest cells produce fibrous connective tissue membranes and spiral into the truncus arteriosus. And again, it's important. It's actually go to the next slide. So I think these two conditions are kind of way out of scope for what you need to know for Anato-Bee, but I wanted to include these because I think it's important to show like the importance of spiralization. So if the septum fails to form like at all, you have what's called a persistent truncus arteriosus, and the name truncus arteriosus is already in the name. Because that's the embryologic structure. So that's basically when the structure itself just doesn't form. So you have all the blood here, and then they mix as they go out, and then like you basically get mixed blood, mixed deoxygenated blood into the aorta and to the pulmonary arteries. And then if the septum fails to spiral, then you have what's called the transposition of the great vessels. And so that's basically where the aorta is connected to the right ventricle, and then the pulmonary artery is connected to the left ventricle. And so basically what this kind of causes is it causes two circles in a loop. So you have all this fresh blood from the lungs is getting pumped into the heart, and then in transmission of the great vessels, it goes into the pulmonary artery back to the lungs. So like your oxygenated blood is in that small loop. And then in the right side, you have all your deoxygenated blood from the periphery coming from your two vena cava into the right atrium, right ventricle, and pumped out to the aorta. You're sort of pumping deoxygenated blood from the body back to the body. So these are very serious conditions that are very serious conditions that are a result of improper heart development. And again, this is just the importance of the spiralization. And again, if anything happens to, say, the neural crest cell migration, you can potentially develop these conditions. All right, so this is my last question. So match the feature to where it came from embryologically. And there's gonna be like one answer here to one answer there. And if you can just type that into the chat.
All right, and I'm gonna say, give it another 5 seconds to type in the chat and we'll move on. So we'll do 5, 4, 3, 2, 1.
Yeah, so this is a little bit more tricky question. This is kind of encapsulating all the different components of my presentation today. So the aortic valve comes from the endocardial cushions. Kind of remember that's when you have like the anchor point that kind of forms all of the valves of the heart. The muscular interventricular septum comes from the ventricular wall, not to be confused with the membranous portion, which kind of has that mixed contributions. The septum primum is part of like the first portion that grows to form the interatrial septum. So that'll just come straight from the atrial wall. And then finally, we have the spiral septum, which is mainly derived from the neural crest. And that's kind of the neural crest causes the spiralization. All right, that's our presentation. Any questions?
Yes. So would is this all where ASD and VSD comes into play? Atrial septal defect and ventricular septal defect. Is that where that all comes into play, or?
Yeah, so when you
Okay.
have atrial septal defects or ventral septal defects, you have there's basically some development issue that has occurred that has basically left a hole in. So one big example for an ASD would be a patent foramen ovale. So patent meaning like maintained, and then foramen ovale is like it just basically once you give birth, then the foramen ovale is still there, and you still have shunting of blood from the right side to the left side. But yeah, that is where that comes from. Embryo or the development of the heart is kind of where those defects come into play.
Okay, thank you. Because during the whole when you started talking about the defects such as that, I was like, okay, ASD and VSD. So
Yeah. We have a question. What conditions are associated with the failure for the septum to spiral?
Oh, it has been quite a while since I've had cardio. I believe one big one, I forget which ones they are attributed to, but I know one huge player in terms of like heart defects is Down syndrome. I know that shows up a lot in a lot of like septal defects and in terms of that. But I think I might have to defer this to Dr. Peterson if you know.
So the big deal, and this is, and it has ramifications for many, many different organs. So just reminding all of you on the call and that are watching this later on, and maybe Kyle can build a little bit on this, but when he talks about those neural crest cells, remember those came from the neural tube as it was developing, and as it closed up, then there were cells that just split off, and they migrate so many different places. But if they fail to split off, if they fail to migrate, or if they fail to migrate in a timely fashion and get to where they need to get to at a certain point in embryonic development, then that can be critical. And so that's a major, major sort of source of the lack of spiralization, is that there was just problems with neural crest migration.
Yeah, and I think it's really important because to understand, especially like going into like STEM fields, is that like when you think about someone who is pregnant, and then like the reason why they go they have so many checkups during the middle of their pregnancy is to ensure that like what is are you, first of all, are you okay as the one carrying the child, and is the child doing okay? And then there are a lot of things like, and when you are pregnant, like there's a lot of certain things you have to be careful of, like what you eat, what you like consume, or environmental toxins that you may be exposed to, because those can really affect the migration of, say, neural crest. And another big one that it comes to the top of my mind is retinoic acid or vitamin A, which plays a huge role in like where things play. So if you take like vitamin A is really important. So if you have like not enough vitamin A or too much vitamin A, then or vitamin A derivatives, then you may have some issues in the process. And there's like many more, many other examples. These are called teratogens, and then there's a whole field of study understanding like how these molecules play in the development of the fetus.
Okay, Sammy, go ahead.
hey, yes. So with all these conditions, and because this is all new to me, I haven't gotten this this far into cardio yet. But so with all these conditions, so if the mother or the carrier is experiencing this, does ASD and VSD come from? Is that what causes ASD and VSD in congenital heart failures or conditions with a fetus or the fetal? Is that why like babies have ASD and VSD? Is because of this? Like, is it because it starts with the carrier and then the carrier affects the fetus, or how does that work?
I think most instances it is like some sort of, because a lot of them, because remember how the fetus is grown is they get a lot of, they get all this nutrition, it gets all that kind of like energy basically to grow from the mother, and then the mother carries that for 39 weeks approximately, and then when it's time to come birth, the fetus can actually breathe properly, it can actually function like there's a reason why pregnancy lasts so long, is to allow the baby to fully develop and be able to sufficient enough once it is removed from like the mother's womb, right? So a lot of it, like a lot of stuff can like what's called cross the placenta, and like you have a lot of like nutrients and stuff like that, and that also can include a lot of like toxins and a lot of other things that can maybe potentially affect the development of the heart, the development of the fetus in general.
Okay. And I also want to say to all of you, thank you so much for this, because I mean, honestly, it's cool. Yeah, sure, I do an internship. That's great, but they don't go in this depth. They'll just say this happened, this happened, this. All right, well, we'll do this, and then because I've gotten to see atrial septal ASD surgery consistent of it, where they will like put in like a kind of like a they kind of like blocked the septal, and it was. I'm sorry. They did.
Why? Because of the weather.
Yes. So as I was saying, yeah, like I said, y'all are going into depth, and like there's stuff I'm just like, whoa, I never heard of that. That's cool. And so I just want to say thank you all for that, because I mean, my notes are I've gotten 3-4 pages full, front and back from. So thank you for that. Thank you. So, and thank you for answering my question, by the way, as well.
Of course.
Well, that might be the last for questions. I don't know if I could sum it up any better than Sammy did, than to just thank our presenters again for doing just such an excellent job of breaking down these traditionally harder, complex topics into something more bite-sized and easier to follow, and still a lot to think about, and still something you're going to need to sit with. But thank you again to our Kyles and Austin for sharing again such a great tutoring session again. So we really appreciate that. Also want to thank Dr. Frank again for moderating, and to our faculty for helping answer questions, and to our participants for engaging in these polling questions, and for making these sessions just so interactive and great. So the only thing that I have to finish up with is just to remind you that our next tutoring session is in 2 weeks from today. That'll be on November 24th, 2024. And again, you guys will get the links sent out to you guys on the Thursday before that session. So with that, I hope everyone has a great start to their really getting into the fall weather, and hope everyone has a great rest of their evening. So take care, everyone.
Bye-bye.
Thank you.